Hi, everyone. Congrats for hanging in there. I'm really impressed by the size of the group that's still here. I am very much respectful of your time, so I'm going to try to move things along quickly. We want to keep our promise to you that we will be done by 5 because we have a great focus group planned for that time. So I was kind of surprised and happy, actually, that in many of the presentations so far today, the word trust has come out. I was trying to keep track, and actually I think that more than half, the majority of presentations spoke something about trust. And I think one of the reasons why we're so focused on it is because we're trying to figure out that missing link or that miracle or whatever it is that's needed to connect all our great ideas and our recognition of challenges and gaps with solutions that are scalable, impactful, feasible, et cetera. So maybe this is one of the ingredients of that secret sauce. Yesterday at our Board of Directors meeting, we were talking about how proud we are to offer funding for grants through APSF. And there was a little bit of a complaint that we never hear about whatever happens. And so I'm here to let you know that this is my disclosure slide, that actually I myself was a recipient of an APSF grant looking at trust between surgeons and anesthesiologists. How crazy a topic is that? But we completed, I would say we're in year 5 now of a 2-year grant. And we are very pleased that we interviewed 40 practitioners across the country in all different kinds of practice settings. And we just completed 2 manuscripts that are going through the review process. So I'm really hoping that you'll be seeing that very soon. And I will pull in a little bit of what we learned in the course of that project in this 15 minutes. So communication and trust. I want to say that we know we have problems with this. We don't always do it well, but also these are our opportunities for learning and for improvement. As Lynn mentioned, I've spent many years looking at reviewing cases where things maybe zigged and zagged and didn't end up the way we had hoped. And when we review them, of course, we're looking for precipitating events that may be targets for improvements and to sort of keep our promise to our patients and to our colleagues that we don't want this to happen again. We want to learn, we take seriously what happened. And when we do those reviews, we find that most of the time they're very multifactorial. But one of the very common themes that seems to come up everywhere is this idea of communication or a lapse in effective communication. And what I find very sad is that when we really look into it and we interview people, we find out that actually, most of the time, somebody in the room knew that something was wrong, but for whatever reason, they couldn't speak up with it, and they couldn't facilitate having a shared mental model for the team so that the team could work collaboratively towards a solution. And so this has actually become a research focus for me, this idea of speaking up. Why is it so hard? Why, as Amy Edmondson says, why do we self-censor ourselves in these critical moments? And why do we do this calculus that somehow makes us feel that the risk to ourself in the moment is greater than the potential risk to a patient? And so I think that this is an area where maybe we can move the needle. So despite our best intentions, errors will happen. And, we often make the example that we don't wake up in the morning hoping that we're going to do something awful or make a terrible mistake, and yet somehow things happen that way. Luckily, not every day, but they certainly do happen. And I think the reason why this happens is because we are bright, we are well-trained, we are well-intentioned, but we're also very human. And the systems that we work in aren't always ideal to help support us bring our best to our efforts every time. One thing that I think also trips us up is the cognitive biases or the heuristics or mental shortcuts that help us act in very expert ways. Through our training in healthcare, we learn how to recognize patterns. We can quickly intervene in critical situations, but also those kinds of mental shortcuts trip us up and sometimes lead us to errors. And a lot of people are familiar with Daniel Kahneman's work on fast thinking and slow thinking, type 1 and type 2 thinking. A lot of what we're thinking about, we don't even realize we're thinking about, and so we don't even know how we can improve or how we can refine our thought processes. So one of the reasons why we have to really work on communication is that communication not only helps our patients, but it helps ourselves. So Amy Edmondson has reported, she's studied this for years and has published, about how the quality of communication is a marker of psychological safety. And the example she gives is in a particular hospital, the number of safety reports about things going wrong suddenly shot up the first reaction was, oh my gosh, what's going wrong in this place? And then she helped people realize that no, that means that the new leadership that's here is providing a safe space where we can talk about what's going on, and it's only through that kind of recognition that we can even have a chance to learn, to study, and to try to make improvements. And then there's sort of this cycle thing that happens where once we improve communication, that then is a driver and mechanism for further improving safety culture. So lots of reasons why we should be working on this. Today we talked about scaling up things that we want to do so that they have real impact. And here we've got all these brilliant ideas, great packages and bundles. How come things aren't really, the needle isn't being moved? And we realize that we're actually in a much bigger ecosystem, right, with a lot more going on, and that distrust is a barrier to dissemination of best practices. If the patients aren't believing in what we're talking about, if they're not engaging with our recommendations, then we don't have hope for better improvement. So individual and systemic distrust affects access to care, management, treatments, and ultimately our outcomes. So one of the constructs that I learned about in doing our APSF-funded study was this idea of relational coordination. Some of you are nodding, I think you're familiar with it. It's a construct of interactions that has been formulated by Jodi Gattel, who is a social scientist based at Brandeis University in Boston. And basically, she's studied relationships, she studied ways, behaviors that seem to foster better relationships. And she's in particular studied how this all works in all different kinds of industries, including healthcare. So she's brought her teams into ICUs, labor and delivery units, and that sort of thing. And basically, she says that relational coordination is something good that we want, and then it has two components: good quality communication, but also connected to that, so it's not just checking off boxes, but good quality relationships. And the way she further drills down and describes these is that good quality communication is frequent, timely, accurate, and problem solving. And when I think about it, isn't that exactly what you want from your colleagues when a patient is hemorrhaging to death or rapidly spiraling with terrible sepsis? And then in addition to that, good quality relationships she describes as having these key ingredients: shared goals, shared knowledge, and mutual respect. And these are things I think that could only foster long-term trusting communication, not only between us and our colleagues, but also with our patients, which we have said in multiple instances today is going to be key for us to really transform our outcomes. So, normally when I talk about this stuff at medical meetings and at anesthesia conferences, I feel a little bit embarrassed because it feels a little bit fluffy and foofy, and I don't have like amazing graphs to show like some of the speakers today. But it turns out there have been many studies that have shown that actually relational coordination, when you get it right, gives you the kind of outcomes that people care about. So these are the kinds of things that hospital CEOs care about, or boards of directors care about, people who can measure and appreciate return on investment. So these are documented in studies. Improve patient satisfaction, decrease length of hospital stay. I think everyone here is hearing about that and having to deal with that. Mitigated harm from inevitable medical errors, mitigated harm from peri-op adverse events, and decreased rates of infection. So these are all things that burden our system, they burden our workforce, and they cost us money. Another way that she has studied relational coordination has to do with what happens when you don't have it. And these are things that I wanted to list because I think they're really important to the safety science and the patient safety folks in this department, in this area, in this room. These are all things that we recognize as being bad and real threats to helping us accomplish what we want to do. So worse performance on individuals' tasks, decreased adherence to safety protocols. So here we are, we've come up with these bundles and nobody's following them. Worse team performance during critical events. More and more we're realizing it's not the value of one brilliant team member, but it's how we all show up together. Decreased worker morale, increased disability, increased workforce turnover. So these are all things that are making our job really hard these days. It's really hard to be a human taking care of other humans right now, and it's getting more and more expensive. Especially during the COVID epidemic, we realized that having relational coordination supports a lot of the key things that really help us show up, be resilient, and in many ways thrive. And a lot of it has to do with the connection that we have with other people in our orbits, connections that are more hardwired by practicing elements of relational coordination. So there have been studies that show increased resiliency, decreased clinician burnout, increased job satisfaction and engagement, self-efficacy, innovation, courage, and gratitude, all things that we like to believe we have at the end of the day as we go off to bed. So this is a slide I added about how we want to think about incorporating these principles in our interactions with patients, because it seems to be that one effector arm is to sort of make things better between ourselves, but another effector arm is to try to apply some of these principles to our interactions with our patients. So as you've seen in other presentations, respectful maternity care. Turns out there have been studies that show that you can train to do this. So either with simulation or otherwise, we can get better at how patients perceive us in these interactions, and this improves patient safety and experience. We need to take advantage of collaborators such as trusted messengers. So, for example, community doulas. A lot of this is in the midwifery literature, turns out. Community doulas improve outcomes, prenatal care, and also continuity of care after delivery seems to be improved by engaging our community colleagues. And also language access. So professional interpreters do improve safety, and patient navigators boost postpartum follow-up. So just yesterday, actually, I had a conversation with Jen Benayan, who, I hope it's okay that I share this, was talking about how frustrating it was to shepherd her own mother through the medical system. And here she's, a pretty medically savvy person, and we were thinking, wow, how awful is that then for people who don't have people plugged into the system already to help shepherd them through. So definitely this is an area where there are opportunities for improvement. So I wanted to summarize at the end with a little bit of a toolbox, if you will. Anything we can do to promote shared mental models. So in our own institution, we're doing a lot more simulation and training during, not only for residents and trainees, but also for faculty about sharing, being very transparent about our thinking, reminding people that people can't read your mind, especially during a crisis where maybe you are speaking less and trying to think and act more. So we're being very deliberate about how we share our information, encouraging closed-loop communication so that it's not just that you said something, but it's that you were heard and you were understood and you can move forward together, and rapid debriefs, so not waiting too long, but sharing the understanding of a situation right away so that learning can be very appropriate, and also identify, for example, if there are devices that need to be sequestered because of a bad event, medications, and how people are doing. And is there anyone who really needs to leave the hospital or a clinical setting for self-care or for peer support and that sort of thing. We're realizing that, sometimes this is hard to do on our own, so our institutions can really help us by hardwiring some of these things. When we do huddles now, we have shared with our surgeons, for example, that it's to their advantage to use this opportunity to invite people to speak up during the case if they see something. See something, say something. And so it's becoming more commonplace for a surgeon to say, hey, this is fourth time C-section, and the ultrasound of the uterus is a little bit suspicious. I'm not sure what kind of bleeding situation we'll get into, and so definitely speak up. Just hearing that from someone really helps other people in the operating room contribute to a shared mental model about the safety situation. It helps people work together. Also, we're teaching, by the way, that if somebody speaks up, if somebody takes the personal risk to speak up and they're wrong, you need to thank them for speaking up, because there have been studies that show that once you say something, take that personal risk, and are squashed for it, you'll never speak up again. So we try to convince surgeons it's actually to their benefit to have people help them. So anything we can do and make part of our standard everyday practice of how we do things will help solidify this kind of safety culture. For example, using surveys, just culture, algorithms, and promoting psychological safety by really having transparency about what's going on, what's learned, sharing the learning so that everybody can benefit, and then therefore there's value to sharing when things don't go well. In terms of patient partnership, we've heard today about the importance of doulas, group prenatal care, continuity models, community boards, and doing everything we can, including with technology, to improve equitable access to the best care that we can offer our patients. So Elliot was saying, what do we do when we're trying to get trust in 5 minutes? So I've been thinking about speed trusting. And in our papers that are hopefully coming out soon, we have some sample language and sample things that we think might be helpful. But today, I wanted to share with you something that you can enact tomorrow or next week or the next time you have some patients, or maybe even when you're talking to your teenage children at home. So, we always pat ourselves on the back when we use the golden rule, right? And our goal is to be very respectful, and so we treat other people the way we would like to be treated, and nothing less than that. And I want to encourage you to instead perform the platinum rule, which is to treat others as they would like to be treated. And in order to do this, you need to take a pause, and you need to appreciate that their values may not be the same as yours. They may not be coming from the same emotional or physical state as you, and you're taking a moment to figure out on your barometer where they are, what's meaningful to them, will just put you in such a better position in terms of instilling trust, being respectful, and continuing a shared decision type of conversation. So I just wanted to leave that with you. And also, you know, this is my last slide. I want to thank you guys for making a difference. You know, I want to make the point that speaking up, teaming, trusting, these are a competency, right? We should be training for it. We should be practicing it. We should be seeing how we're doing it and measuring the impact of these communication and trust issues. It's good for our patients. It's good for us. And this last click is something that I learned from Jeff Cooper, who, you know, we can't have an APSF meeting without talking about Jeff Cooper. He likes to challenge his audience to put into action whatever it is you've heard about today. And so I want to ask you guys, how do you or will you incorporate teaming, talking, and trusting into your work? This is my email. Take a screenshot of it. If you send me an email in the next 30 days. I, first of all, would love to read about it. And I'll do a hand lottery and randomly pick someone to get a $50 gift card. So thank you.